This topic is lumbosacral disc herniation and radiculopathy. Let's talk about the pathophysiology. Lumbosacral, that's in the lower back. That's normally where people have problems because that's the area that the back moves the most. Now let's talk a little bit about anatomy. Between the vertebrae, you have the discs. That's that blue part in the illustration. The discs cushion the vertebrae. It has a cartilaginous ring around the outside and then a soft jelly middle part. Now, when people have problems with their back, it happens in a couple different ways. The first way is that it can be a herniation of that disc. So remember, you have the vertebrae and the disc in between the vertebrae, and those nerve roots go off the sides. A disc will herniate off the side and then cause problems on that one singular nerve root. You can see that in the picture here. It presses on that nerve root, and that inflammation then causes clinical manifestations to that one area. The client may feel weakness in a leg or paresthesia in that leg. They'll still be able to walk, and they normally have to let it rest to allow the inflammation to come down. Another way a person can hurt their back is if the herniation or bulge goes towards the back and hits and affects the spinal cord. The client will have clinical manifestations like they have a spinal cord injury. They'll have weakness and other symptoms in both legs. A third way an injury can happen is if the herniation happens at the base of the spine, where all of those nerve roots are coming out. Numerous nerve roots are branching out, like in the illustration. If the injury or herniation or bulge happens there, numerous nerves are affected. The client will have bilateral weakness and may even have bowel or bladder complications. Herniations and bulges are common at L4-5 and L5 to S1. Risk factors include advanced age, breakdown of that tissue and bone, frequent heavy lifting with overuse injuries, and improper body mechanics. So if somebody injures that area, now they'll have a problem in that area. Other risk factors include obesity, which causes extra stress on those muscles and those bones. And finally, smoking is a risk factor because it's been linked to disc degeneration. Clinical features include radicular lower back pain. This is back pain that starts in the back but radiates to the legs below the knees, and it's relieved with bed rest. This pain normally is exacerbated by any actions that increase intraspinal pressure, like lifting or coughing or straining. Clients may also experience lower extremity paresthesia. This can happen in one leg or both legs, depending upon where that area of injury occurs. That paresthesia is tingling or prickling like needles and pins. The client may have absent or diminished reflexes. An S1 injury affects the Achilles reflex, and an L2-4 injury affects the patellar reflex. The client will also have a positive straight leg raising test. Let's watch this animation of the straight leg raising test. A complication is cauda equina syndrome. It's called this because the bundle of nerves in this area look like a horse's tail. This results when compression of numerous spinal nerve roots in this area occurs. You can see all of those nerves that will be affected. Knowing this will help you link the clinical manifestations. This normally happens with a herniation between the L4 to S1 area of the spine. The client will have bilateral radicular pain. They'll have severe back pain. They may have progressive leg weakness in one or both legs, and they may even lose their ability to walk. They may have flaccid paralysis of their lower legs with no muscle control. The client may experience one-sided or bilateral paresthesia in the buttocks and perineal area, and the client may experience incontinence of their bowels or bladder. This is a medical emergency. They must have surgical decompression of this area within 24 to 48 hours so that long-term nerve damage can be avoided. Nursing interventions for these clients include alternating hot and cold compresses. You can use the hot for those muscle spasms and cold compresses to decrease inflammation. We can administer medications like NSAIDs for pain and muscle relaxants for muscle spasms. We want to encourage the client to lie on their side, with their knees and hips slightly bent. We can place a pillow between their knees to help relieve pressure off of their knees and hips and back, and that'll also help relieve some back pain. Strict bed rest is not recommended. This can increase the risk for re-injury and also can cause more pain. We want to encourage the client to maintain as much mobility as they can. They can do stretching and strengthening exercises as tolerated. We want them to strengthen their core and their back. Clients may seek other healing therapies, massage, acupuncture, manipulation. And some clients may need to have surgery, and we'll talk about that in a little bit. In our client teaching, we'll want to include weight control. Weight loss may help with decreasing pain by decreasing the strain on those muscles. We also want to teach them about proper body mechanics. All of those body mechanics we use as nurses, we want to teach our clients. We want to teach them about establishing a wide base of support with our feet underneath our shoulders. We want to encourage them to bend at the knees and the hips when they go to pick something up versus bending right at that back. We want them to maintain a straight back, keeping those shoulders over their hips. We want them to avoid that twisting motion because that can cause strain on the back. And then we want to teach them to avoid lifting heavy things above elbow level because this could possibly cause strain on that back. As I said earlier, some of these clients will require surgery. The clients who still have unrelieved pain, no other measures have worked, or the neurological deficits have continued to worsen. Also, a client who has cauda equina syndrome. We want to make sure anytime we're moving the client in bed, we're making sure that their spine is kept straight. So if we have to turn them, we're going to do that in a log rolling technique. Again, we want to keep that spine as straight as possible. You'll want to follow the orders for positioning and limitations for each client. They are specific for the injury and the surgery that the client had. We'll administer analgesics for pain, and we'll monitor bowel and bladder function. Remember, depending upon which nerves are affected, could affect bowel and bladder functioning. We'll want to administer stool softeners, especially if we're using pain medications. And we may have to catheterize these clients. Wound care will include all of those normal wound care things we do for every client, but we want to be very specific when we are looking at their dressings. You can see here in this illustration, we want to look for the halo sign. You can see the reddened blood area in the center, and then a halo of clear fluid around the outside. This indicates a cerebrospinal fluid leak. If you see this, lie the client flat and notify the surgeon immediately. This indicates a tear in the dural layer covering the spinal cord. Normally, the client will be kept flat for a couple days to allow that tear to heal. We want to advance their mobility as tolerated. We want to get them moving as soon and as safely as possible so we can avoid complications of immobility. And we can always set them up with assistive devices so they can return to their regular daily activities. Keep up the good work. I'm proud of you.